Now we will go for panel discussion. I request chairpersons to be on the dais on chairperson seat. I request Dr. Ashim Desai sir as a moderator to be on the dais. The topic of discussion is evidence-based versus experience-based management of allergic rhinitis. I request all panelists, Dr. Vikram Khanna, Dr. Anita Baptiwale, Dr. Gaurav Agarwal, Dr. Prashant Kewle, Dr. Deepak Haldipur, Dr. Rupali Jain, Dr. Sonali Pandit, Dr. Avinash Borade, and Dr. Santosh Latkar to be on the dais as a panelist.
So, good afternoon, ladies and gentlemen. Once again, I'm here with you talking on allergy, and I have the veritable who's who of allergy in India. And I have a co-moderator, Dr. Deepak Haldipur, and he's an amazing guy, and he's also deeply into allergy, so I thought that maybe it'll help. So, the panel is the who's who of allergy here. I think I will turn myself around. Okay, and the questions that we want to elicit is what should we do with this kind of complicated scenario? Because allergy is not alone. There are a lot of comorbidities, a lot of issues attached to it. So my first question to you all is, what importance do you place to the ARIA classification when you are confronted with a patient with nasal symptoms? I will not say an allergic patient, a patient with nasal symptoms. Let's start with Rupali.
Hello. The patient with nasal symptoms, if it's intermittent, like he's only having symptoms like less than 4 days per week, then I will go with pharmacotherapy. Maybe oral antihistamines or intranasal antihistamines with corticosteroids.
No. Sorry, the question is how much importance do you give ARIA? And the second part of the question is that how do you document the history? I mean, do you have a SNOT 20? What do you do? So that the audience knows how to sort of classify the patients. Do you do a SNOT 20?
No, I don't do. I have an allergy questionnaire.
Yeah.
And accordingly, I ask for all the symptoms, and accordingly.
Santosh?
Actually speaking, what we come across is almost all moderate to moderate severe patients. Okay. Yeah. Intermittent and mild cases we hardly see because we are sorts of a tertiary care center for allergies. So question of intermittent and mild does not come to us. For me, what I do is go for a detailed clinical history and then SNOT scoring. SNOT scoring I do.
Okay. Vikram, anything different?
Nothing different except that a detailed history is very important.
Absolutely.
Plus, not only the duration but also the severity, so that you are clear in your mind whether you are dealing with rhinitis or rhinosinusitis, and if it is rhinitis, whether it is allergic or non-allergic.
Prashant?
So nothing, only for the patient, those who are on
Can't hear you.
immunotherapy. Those who will be on immunotherapy, for them I do SNOT score, otherwise
Okay.
no.
But you follow immunotherapy with a SNOT score?
Yeah,
And
for the immunotherapy. Yeah.
Anita?
So this varies. Actually, if the patient comes for the first time, then I don't give much importance to area classification. I'll be giving them symptomatic medicine and then they'll follow. But mostly I get patients who are referred, who have already gone to the general practitioner. So in that case, I'll be... so I do the SNOT 22, not the SNOT 20, and if they have associated asthma or for this thing, skin or any urticaria or any other symptoms of angioedema, anaphylaxis, I have my whole questionnaire for patients who generally come in for allergy testings and have a full documentation of how it is going along. Accordingly, then once I proceed with the allergy test, then I proceed with the management for that.
Avi?
Yes, sir. As sir said, first the history, clinical examination, and we are regularly following with the SNOT 20 score. We are taking proper, questionnaire for the patient, and accordingly we will start with the pharmacotherapy first.
Yeah.
Similarly, sir, I go with this. I take the history also. I also counsel the patient to go for spirometry.
Yeah, that's a good point. Yeah, okay.
If we are planning to counsel the patient for a skin prick testing, then the patient has to be optimized.
Sonali?
Yeah, I have my own questionnaire, and there are specific questions. You know, where do you live? What kind of ventilated, like whether your house is ventilated, whether you, I don't follow area per se, but we have got separate questionnaire along with SNOT 22 scoring. But I will start with pharmacotherapy in moderate to severe cases. Yeah.
Take-home message would be to have a proper history. That is extremely important. The second one is to have some form of documenting what the patient has, because the patient can confound his own history. So when he tells you something on a date and then he comes back and say there's no improvement, but you ask him specifically on particular points and he'll get up and say, okay, look, there is improvement, and it is good for him as a patient or her as a patient to see the visual analog scale change over time. So we went over that. Now, when will you image the patients? What are your indications, apart from gross polyposis, when do you image your patients? Sonali.
If the patient is complaining of headache, facial pain, if I see obvious nasal polyps, just for plain simple allergic rhinitis, I won't image the patient.
Correct.
Associated complications.
Yeah, no. Polyposis, of course, you'll image it.
Yeah.
Assume you see no polyps, you typically don't image, right?
No.
Yeah.
I prefer to do a nasal endoscopy rather than imaging, because imaging usually sees the things like DNS. It gives you that the patient is having DNS, and the patient is now then biased, and he comes with a report sometimes that he is having a DNS. But if you are doing an endoscopy and your scope is easily going till the back end, then probably DNS is not the reason, and then you can explain the patient better.
Any other points?
For me, sir, nasal obstruction is a main symptom. If patient is having a post-nasal drip, then having a severe blockage or persistent blockage is complaining, along with frontal headache or a history of previous
So unexplained symptoms with a clear nose, with endoscopy, you would image. Yeah, absolutely. Any points? Prashant, you wanted to say something?
To add is that once you start the treatment, patient is asymptomatic, that time you do image. Not when the patient is having history and coming on first day, you should do image.
So maximal medical therapy.
Medical therapy.
Define maximal medical therapy. What do you do?
I will not do imaging.
No. What is your concept of maximal medical therapy? When would you give the antibiotics? What is your concept of maximal medical
Minimum
therapy?
7 days of your therapy.
Yeah.
And then if there is no improvement, we should go for it.
Antibiotic of choice, Anita?
So it will be generally depend on the patient's history. So amoxiclav, I'll start with generally, and along with probiotic therapy, and for a course of 7 days. And that is only if the patient has, say, in primary patients, I won't be giving antibiotics. I have minimized the use of antibiotics nowadays. So I'll be just giving, say, anti-allergic decongestant, then corticosteroid and antihistaminic nasal sprays. And if required, only I'll be giving the course of oral corticosteroids.
Ashim bhai, one indication for imaging would be anosmia, and if epistaxis is a component of the patient's symptom profile.
Of course. Yeah, perfect. Rupali?
Basically, blockers we have to investigate thoroughly. Along with DNA, as you very correctly said, the symptoms which cannot be explained on the allergy background, we have to go in for imaging.
Patient more than 25-30 years of age, if he's coming with the symptoms, I will do imaging to rule out central compartment airway disease.
Okay. Now, as part of your workup, when will you subject the patient to skin prick test? Most of you do skin prick test, right? Any one of you do exclusively blood testing? So all are agreed that skin prick test is the gold standard for diagnostics of allergy, right? Okay, so after how long will you do a skin prick test? How do you filter your patients? You can't possibly do a SPT for every patient with a nasal symptom. So how do you filter your patients?
So when the patient comes, I ask, after taking the history, if he is suffering from a long duration, and after doing a nasal endoscopy, I find that the symptoms are relevant to allergic rhinitis, then I ask them to do a skin prick test. Otherwise, I first continue a pharmacotherapy for at least 1 or 2 months, and if they don't get relief, then I go for skin prick test.
For me, nasal steroid sprays for 2 months. After that, go in for serum Ig levels hemogram, find out the eosinophil count. Eosinophil count still high and patient is not responding to pharmacotherapy, then I will convince him to go in for skin prick test and followed by immunotherapy.
No, but Santosh, evidence has shown that IgE is not representative of your allergic response. So I would respectfully differ with you from that, because IgE levels are not an indicator of pure allergy at all times. Sometimes you can have low total IgE, because ultimately what does the blood test measure? Blood test measures the serum IgE levels. But what we are concerned with is what is bound. The bound IgE makes the difference. Vikram, any point?
Yeah, so in the first visit, I have a good estimate whether this patient has allergic rhinitis or not, and the counseling for the test starts then. Patients get the test done once they are symptomatically relieved. This may be either in 3 to 4 weeks or maybe later in chronic sufferers. But they are advised to do the test to identify the allergen with a clear message that pharmacotherapy is only going to relieve the symptoms, but the patient will never know what he or she is allergic to. We need to identify that, avoid that allergen, and in certain cases, immunotherapy may be required. But always a time gap of 4 to 6 weeks after the patient is symptomatically, relieved and is on topical medication, so that the oral medications do not interfere with the skin.
It has to stop. Agreed. Yeah.
So when do you stop what is the time gap between the oral
usually,
medication and the test?
So oral treatment is for maximum 2 to 3 weeks.
I'm not asking you that. When do you do the test after you stop the oral treatment?
How soon? What's the time gap between
After
medication?
a week, 1 week to 10 days maximum. But if the patient is on Ayurvedic or homeopathy drugs, then it would take at least 2 to 3 months to discontinue them, because they are known to affect for a long time.
One more question to the panelists. Is there any value at all for IgE estimated tests, number one? In conditions where you can't do SPT, what would you do?
So in that condition only we will go for the blood test, because the tattoo is there or some other problem is there and we can't do the SPT, or the kid is too small, then it's fine to go ahead for a skin blood test.
So I don't do IgE on a routine basis. And so skin prick test we do in the majority of patients, only patients who have, say, chronic urticaria and they cannot stop the medication, then only I go for blood test.
So about IgE, in Indian scenario, there is a study published that Indians have got relatively higher IgE levels as compared to others. And negative IgE is probably, IgE less than 50 probably is an indicator of non-allergy, but higher IgE does not prove that it is allergy.
No, IgE levels, decreasing IgE levels will help you in giving a better
serial
prognosis.
titration.
Yeah.
Serial titration.
Being ENT surgeons, most of the patients who are coming to us are already suffering from, say, months. So they have already taken a pharmacotherapy, and most of the patients giving a history that I am taking medicines, I am feeling better for a few days. But again, the symptoms are recurring. So as sir said, the advice for allergy test starts in the first consultation only if this is the history that is suffering from few months. Patients are coming to us suffering for many years also. Then obviously with the examination, we know that this patient is having typical history, and clinical examination also proves that patient has typical allergic rhinitis. So if patient is willing, we ask them to stop the medicines, antihistaminics for at least 4-5 days a week, steroids for a week, and accordingly we convince the patient. And only, I think, in pediatric age groups, we are doing blood tests, because obviously a kid cannot have a cooperative this thing for the skin prick test. Or a patient who is having very severe skin diseases where we cannot do, or there is a risk of reactions, then we are advising them for the blood test.
What blood test do you do?
So we do the immunocap method.
Anybody else does anything else beyond the immunocap? CRD. You do the Alex?
Yes.
Okay.
One small additional question.
Yeah.
You have a typical patient, classical allergic rhinitis, no mistakes, all features in favor, IgE in favor, absolute eosinophil count in favor. But your well-done SPT is totally negative. Then what do you do?
So this could be a case of local allergic rhinitis, where the symptoms are mimicking, but it's a local reaction of the nasal mucosa. So for this, we have the options of either doing a basophil activated time test or the nasal allergen challenge.
Basophil activation is not yet freely available in India, so nasal allergen challenge is the way forward. That's a very important point Vikram brought forward. Those you find that the SPT negative and all the other symptoms of the and falling into the ARIA classification, look at local allergic rhinitis. One of the things you can do is do a nasal swab, a nasal smear to see the eosinophils. And more than 10 eosinophils per high power field, you can conclude that this is local allergic rhinitis. And in those cases, you do an NAC, nasal allergen challenge. You can use the aqueous solutions of the SPT, not the glycerinated solutions, with saline on the opposite as a control for C, because some people just start sneezing away irrespective of what you put. Even if you don't put anything in their nose, they start sneezing. So do a control with saline, and then you can use an aqueous solution of the common aeroallergens, dust mites, fungus, and a couple of locally occurring pollen. Any difference on this point?
You have to put it in a, how we give that nib. So it will be more, because even that putting that drop, that starts.
So that's it. You do a saline to start with,
yeah,
to make sure he's not responsive.
Not irritant,
yeah. And otherwise you use a neb, correct. But again, when you use a neb, the concentration is difficult to determine. How much is going inside? Here you can say, okay, X number of 2 drops, 3 drops, whatever it is, at least you have some idea. In a neb, you won't have an idea. But if they're too responsive, they just start sneezing. If you touch their nose, neb is a good idea. Any question, any points you want to additionally add? Okay. Now, there are the contraindications like uncontrolled asthma, markedly compromised lung function test, arrhythmias, uncontrolled hypertension, and so on and so forth. And you can't stop a beta blocker, you can't stop ACE inhibitors. What do? You do the blood test, of course, right? So from the treatment perspective, I know I've originally given 1 hour, 10 minutes, then it got shortened to 45 minutes, now it's shortened to 30 minutes, so I had to go really fast. I'm sorry. Pharmacotherapy. Antihistamine of choice, primary antihistamine of choice, each person, please, Sonali.
Again, depends on patient's profile.
Yeah.
Young kids, I would give them levocetirizine. At night, they sleep well also. Working class patients, fexofenadine or bilastine. Cetirizine I don't give because of the sedation. And it also depends on a lot of patients who take levocetirizine don't get sedation. A lot of it is personal based.
Variable.
Yeah, so anything, levocetirizine, fexofenadine, bilastine depends on the patient profile.
So when do you choose bilastine versus fexofenadine?
So I would choose bilastine with patients who have liver problems or kidney problems. Normally also, I would give bilastine nowadays because of the beta safety profile as I would give fexofenadine. So I'm kind of
switching over.
Yeah, to bilastine. Yeah.
Gaurav.
Sir, my first preference will be to go for an INCS. If the patients are well with the INCS only, then probably not to add any antihistamine, because if they are doing a good nasal saline irrigations and are using INCS, more than 70 to 80% are well relieved. I feel so.
So intranasal steroids, and for adults now bilastine is the drug of choice for me, and for children of course levocetirizine or cetirizine.
Anita?
I use a lot of levocetirizine and fexofenadine. I don't have much use of bilastine, and intranasal corticosteroids in combination with azolastine. So that will be the initial therapy.
Prashant?
So if the patient is poor, cetirizine. The patient is affording fexofenadine.
You don't get poor patients, so it's okay. Vikram?
So the initial pharmacotherapy is with an oral agent, which is stopped after 3 weeks and converted to a nasal spray.
So you start with oral and then change over to nasal?
Yeah.
Oh, not simultaneously?
No.
Okay.
Your question was for the oral antihistamines. So fexofenadine for me right now is the drug of choice. I don't have much experience and much satisfaction with Bilastine up till now. So fixofenadine and then intranasal corticosteroids, they score excellent for everything.
For pediatric patients, I give levocetirizine, and for adults, I also give loratadine. Loratadine is also given good results, as well as Bilastine.
In fact, bilastine has not added any extra value to the existing array of antihistamines.
I kind of agree with you, Deepak, on this. But yes, FEX is very good for, as she rightly said, people who are working on a daily basis, and you can give loratadine stroke, desloratadine.
And
Loratadine and Avastin also.
my
Avastin is also
experience
having
has
a
been
role.
that levocetirizine actually is more sedating than cetirizine.
Also, sometimes our choice is also decided, whether the patient comes to us early or whether he has visited few doctors and then come to us. So we need to sometimes give something different which has not been tried, and most of the time it works because they are also fed up, said they don't take our instructions
No, that's a
very
very
seriously.
practical point. And sometimes two patients come from the same family, you have to write two different drugs.
Correct, sir.
Absolutely.
See, this is what practice enhancement is called, a la Deepak Haldipur. Two different antihistamines for brother and sister from the same family. Well done. Thank you. You've given me a tip to take home. Okay.
Only a sound commerce can support any science.
That is true.
Then the question will be that you have given it to us, can we use for a third person who hasn't come or third sibling who hasn't come?
Why not?
Which one?
Why not?
Which one can we use?
Why not?
Okay, coming to immunotherapy. What is your tilt factor to initiate immunotherapy, Rupali? When you start? When do you start? I'll come to biologics much later in this, but let's talk of immunotherapy first.
Okay, immunotherapy, depending again on the patient's severity, and after doing skin prick test, especially if he is positive for house dust mites, because I've seen in my practice, I've been doing like now for 5-6 years, they respond wonderfully to house dust mites. Pollens, yeah, there is a slightly this thing. So if they correlate with the history, then I start also on pollens. But house dust mites, yes, immunotherapy. So I give sublingual.
Basically, as sir said, patients come to us at a quite later stage. So initiation of immunotherapy or priming for immunotherapy starts from the first visit. Okay. Pharmacotherapy goes for a month or so. After that, they also get fed up, and we also have a point to say that now this is the time to go in for skin prick test and immunotherapy. My advocation is skin prick test along with immunotherapy. I do not wait. Okay, but then the success rate to go conversion of the skin prick test to immunotherapy is around 50 to 60%. So everybody going in for skin prick test does not go in for immunotherapy. Maybe there are economical barriers or something of the sorts. But then this is what I see in my practice.
Vikram, what's your tilt factor? When do you start immunotherapy?
See, immunotherapy is advised as the treatment of the disease, and pharmacotherapy is advised as treatment of their symptoms. And this is constantly drilled into the patient's psyche from the first visit. For persistent sufferers, immunotherapy is, I sell it to them. For the intermittent sufferers, I make them buy it.
Sir, I always tell the patient you have to start the immunotherapy. Just to explain, if you have a fever, you are taking crocin. But crocin is not the treatment for the fever. We have to go into find out why the fever is there. So you can ask the patient, what is the cause for your allergy, your sneezing, where to find out. So imbibe, also we know the allergic march goes on. So we are the one who have to prevent this allergic march and get the better one. So 100% we have to insist from the first visit that something immunotherapy is there, which will at least give some switch. So you should.
Anita, any other points you want to add?
So the patients, when they come in for allergy testing, they are constantly already on immunotherapy and its benefits. And this depends on, say, the positivity of the response. Mostly, say, I have documentation of the follow-up also of immunotherapy. So mostly 80-85% of it is dust mite, house dust mite. So it comes, say, from the range will be 5 to 12 millimeter wheel. And then it depends on the prevalence in the environment and the clinical significance. So if, as majority of patients are office going and students, they definitely need a dust mite therapy for house dust mites. So it will be like, say, most of the patients will be going for immunotherapy. If the skin prick test is negative, then obviously in those patients we don't give.
Any other opinions?
Even when the patient visits, we give them a scientific data also. So that this immunotherapy is the only disease-modifying treatment, and it can cure, or it can at least give you a scientific, natural, and without any side effect treatment. As anyway, people are going for homeopathy or Ayurveda, where we don't we know that there is no sufficient evidence for us to get convinced. So we give them a scientific information also, give them a idea that if you do not treat the disease, it will give rise to sinusitis, polyposis. There are 25% high risk of developing asthma. So we have something which is disease modifying, and this is a proven and scientific treatment. And convince them to obviously go for the skin prick test. And because we are doing skin prick test is not only for knowing the allergens, but we can treat you also, because patient will ask you after doing the test, what is the next, how you are going to treat me. So we have to give them all the idea, then only they will be more convinced and they will believe us.
Even I don't hesitate to start the immunotherapy at the first, especially in the children's, because probably, as Sir has also said, this is only the disease modifying thing available which can help to at least cure or prevent asthma also in children's. So it should be started as early as possible. And of course the patient, they also loses patience, because immunotherapy is not going to start working from day one. We anyhow have to keep the patient in follow-up for 6 months to a year to have him that effect what he wants. So till the time he should be with us, he should have some pharmacotherapy for immediate control, and then the immunotherapy for the later control.
Yeah, for immunotherapy, I would say catch them early and catch them young.
Yeah,
Extensive
very right. The younger they are, the
counseling.
better they
Yeah.
work. Absolutely, very relevant point you made. Okay,
I think one important point is, if you look at the homeopathy fellows, the Ayurvedic fellows, the first line they tell people is, our treatments take time. For various reasons in the last few decades, allopathy is known as a shotgun therapy, and patients come with that idea. So I think if you can sell that point first, the rest becomes easy. Second is, the first visit when you are sending them for skin prick test, you have to introduce the concept of immunotherapy then and there itself. And now with sublingual thing becoming more common, it's one of the easiest things to give and take.
So now, one point, even we just for patients' language and understanding, we call it vaccine. And we give them example of even COVID, that it's only one dose is not enough. So when we are giving immunotherapy, we are giving a primary dose and then booster dose also. So this concept is also told to the patient that it needs time to develop a robust immune response.
And basically the success of any therapy is identifying the correct patient with the correct mindset. It's not enough only if the disease is ready. The patient has to be ready.
Or you train the patient to become ready. You change his mindset.
I think the most important point is time spent with patient, right from the beginning to skin prick test, to immunotherapy with follow-ups. What I do is every month I call up this patient.
The conviction in the therapist's mind about the therapy.
Right. You should be convinced
Yes,
that this is going to work.
Yes.
Then and then only you are going to convince your patients that this is going to work.
So I think the summary amongst the panelists as well as the moderator is, one, that pharmacotherapy and diagnostics should be started almost simultaneously. Two, when you are talking of allergen immunotherapy, you have to tell the patient that it's going to take some time, it's not going to happen overnight. What the analogy I use is that tomorrow, if your child goes to the gym, day after he can't turn into Salman Khan. He has to take 2 to 3 years for the body to change, and the same thing is going to happen with immunotherapy. So you are already pre-sensitizing the patient to what comes next, and you also are giving shotgun therapy temporarily to alleviate his symptoms, and you tell the patient that, look, it's going to take 4 to 6 months for the real effects to kick in, and till that time you will continue to suffer. So the point here, very correctly mentioned is by Santosh, is that spend time with the patient to explain what's happening. Then compliance is better, your results are better, patients are better, you get happier, you get more referrals, as you said. Now, how do you choose the correct allergens? You have maybe 15, 20 positive tests. A lot of us do about 100, 120 tests or so. Out of them, 20 come positive. You can't possibly desensitize for 20. So how do you choose, Rupali?
So based again on the history, an elaborate history, I will see what is he's positive to. Like if he's positive to dust mite, then definitely. And pollens, many a times, a lot of pollens. In my practice, I've seen almost like sometimes even 15, 16 pollens, they come positive.
But that
So in
is
such
because of
cases-
the PR10 proteins,
Yes, sir.
polcalcins and all
Yeah.
that. So that's cross allergy.
Yeah,
So how do you
cross
choose
allergy.
your pollen?
So, sometimes the patient will tell that he has symptoms in some particular season. Now, recently, as I had a patient, he had symptoms only in the winter season. So, all the pollens, they were positive. They had the pollination period during these months only. So now, in that, I again then chose the cross-reactive, and I decided the.
For aeroallergen pollens, again I will take help of the pollen calendar and find out exactly whether it is relevant, that pollen is relevant or not. As you said, there is cross sensitivity, so that has to be ruled out. But for me, the most important thing is the dust and dust mite. So if it is positive, again Blomia has to be given separately. Rest two can be.
So I'm going to ask the next question to each and every panelist. I want your opinions. What is the maximum number of allergens you should give? What is the minimum number of, minimum, of course, you can have one allergen, that's fine. What's the maximum that you can give? How many have you given?
I've given 4 up till now.
Up to now.
As I said.
Of different groups or the same group?
No, different groups.
Okay. Vikram.
So choosing the allergen for immunotherapy would depend on 3 things. Number 1, the strength of the positive reaction. If there is pseudopodia occurrence in the skin prick test, then definitely yes. If there is multiple sensitivity, the second history, taking help of the pollen calendar, and then now we have the CRD also available. And as you pointed out, minimum 1 allergen, maximum 3.
You?
Sir, maximum 3 groups where we can mix. If you have a pollen, you have 1 fungi, and then dust mite. So we can have 3 groups can be given.
Anita?
So it's the same. I have mentioned it already. So it depends on clinical relevance and strength of the positive reaction. And so like the same, maximum 3 groups. And so the dust mites, and then the second one is for the pollens. So what are the maximum wheel and the cross-reactivity of the pollens? And for the other allergens, say for fungal allergens is less, but say for pet, if there's an exposure to pets or for a pigeon or for for epithelia or anything or insects accordingly, then I'll be giving for that.
We are giving 3 groups.
3 groups. Any?
Of course, 3 groups, sir. Only thing I want to highlight is what not to be done. Because we do some food testings also, food allergen testings, that is only for the patient satisfaction and they don't have to be treated at all.
Correct.
That is
Absolutely
important.
correct.
Positive will mean sensitization. So if patients they insist on food allergy testing, they means I give them the offer of giving only the inhalant allergens. But then they say they want to do the whole test. So in that case, if they come positive for irrelevant foods, then I tell them to keep a food diary, and only if it is relevant, you don't have to stop eating that certain food. And say dust mite patients, they have quite a lot of positive to shellfish like shrimp and prawns because of the cross-reactivity between tropomycin and this under P10.
So we have observed there are patients who have skin reactions also. Then the food becomes more relevant for them. And with the precautions, it helps.
Any other points you want to bring up? Okay, so 3 points I want to mention. As they all correctly said, history taking. Now imagine that your patient says, look, I wake up in the morning, put my feet down, I start sneezing and so on and so forth. It's most likely dust allergy. If a person says it's a seasonal issue, it's obviously a pollen allergy. And sometimes he says, I'm exposed to central air conditioning, so on and so forth. It can, in a humid climate like Mumbai or Dubai or something, it will be a fungal allergy also. And in fact, desensitization into fungal allergens is a controversial point, but today there is documentation that says that you can desensitize to aspergillus particularly because AFRS and CCAD with positivity to fungal allergens is the cure. The treatment of choice would be immunotherapy along with whatever surgical intervention you want.
In
Now,
case serum IG will show pre and post in AFS, allergic fungal sinusitis.
yeah, but pre and post should be spread apart like maybe 1 year apart or more than a year, not very quickly. So now mixing in the same vial, there are a couple of people who, companies in India who mix multiple allergens from different homologous groups in the same vial, and that is mentioned to be condemned, except pollens can be mixed, dust can be mixed in the same vial, but you never can mix a dust, pollen, or something else. Or like a fungus, for example, because of the proteolytic enzymes of the fungi. So is there any doubt on that one? Are you okay to mix? So another point is absolutely, now there is a difference between the European protocol for allergy and the American protocol. I personally believe that the American protocol is more for the financial gains rather than the real gains. The European protocol is very clear, 2 to 4 max, which each and every one of the panelists has agreed, especially of different groups. The confounding fact, can you go back please? Yeah. Confounding fact is there are some people who measure allergic units, some people who mention biologic units, some people who mention protein units. It's very, very confounding. So how do you choose the patient response? Rupali.
I didn't understand your question.
No, how do you choose your patient response? How long do you wait before the patient starts responding?
No, I at least wait for 1 year. I ask them to wait for 1 year. Then I again, if they say that the symptoms are same, then I ask them to stop it and I continue on pharmacotherapy.
Santosh?
After primary dose is over, I mean, as I said, every month I'm going to have a follow-up and I'm going to talk to the patient. But after a primary dose, that's around 3 months, then I take up the look. But then the second dose goes off. After 6 to 8 months, I will have that look at the snort chart and then I will decide.
Vikram?
So the patient symptoms.
So, sorry to interrupt you, but so you will wait for 6 months, do a fresh snort score and then decide. Perfect. Very good. Perfect.
So
yeah.
in the initial months, the symptoms increase, which is explained to the patient, and they are put on appropriate pharmacotherapy measures, depending on their choice and their, this thing. After 6 months, the snort score is repeated. After 1 year, the serum specific IG for those antigens are checked. If all the three correlate, then the immunotherapy is continued, and explaining to the patient so that there is evidence in front of them and not just my coaxing them or they feeling not fully satisfied or fully relieved. So they are, as you said, a child going to a gym will take 2 to 3 years to get the body that he or she desires. So we also explain this in each and every visit.
Sir, actually once you start the immunotherapy, the first dose is there at least goes for 5 months. Yeah. You keep the patient for 3 months on your antihistaminic. And then if the patient still says after stopping the medicine, he is having symptoms, it's a time for you to relook. Are you dealing with something else also? So some pollens are missing. So that time you go again in history, again you see your SPT, is it correlating, not correlating? And then you may have to do some provocation test and add something.
So generally in the initial doses, how it works for the patient, because it depends a lot on patient compliances that you've given this medicine, whether it's working or not for them. Then accordingly, they've given the choice after that. If they want to continue, I change the dilution also, and I look for other things also. What is the other cause for the symptoms not to be subsiding?
Initially, we give a proper plan for the patient that this immunotherapy is going to be there for say 2 to 3 years. It is explained to the patient that minimum 1 year, don't worry about the immediate symptomatic relief or something because it is going to take some time. I ask patient to follow up every 3 months. Then again 6 monthly we will again take the snort score and evaluate.
Yes, sir, we also evaluate, but not before a year that we look into the testing again.
Okay. So minimum 1 year you
1
should
year,
wait.
yes.
Yeah. Sonali?
1 year.
Yeah, 1 year.
And then I also tell them initially that for various, like for unknown reasons, 15 to 20% of them don't respond to immunotherapy. We all know immunotherapy is doesn't have 100% results. So initially you tell them. So it becomes little easy after 1 year if they are not responding, that they have already been counseled for that.
I tell my patients that 80% of immunotherapy will be relieved. Is there any discrepancy amongst any of you? No. So 20% failures is a must. What do you do when you have a failure? Do you operate?
Sir, but
a
usually
posterior nasal nerve section, for
failure,
example.
all the failure patients also have little decrease in the symptoms at least.
We hope. So minimum duration is 3 years, and it, as Sonali very rightly says, more effective, catch them young, treat them young. It's much better. Next. And it also prevents the allergic march. And what is the youngest age that you have given? Immunotherapy, Sonali. What is the youngest age?
6 years.
6 years. You?
4.5 years.
You?
5 years.
5 years.
4 years.
4. 5. So let's take a cutoff of 5. 5, okay? So immunotherapy under 5 years should be not really encouraged unless there are gross indications for that. Now, what about...
I think the limitation is for the test itself. 2 young children, you can't do it properly. Yeah. So I think 4 is still okay.
No. The point is that the immune system is still building up. Yeah. Remember, IgE was created in our bodies for helminthic infections. So that is why there is such a huge overload of allergy in the urban population vis-a-vis the rural population. Because the rural population, the IgE gets digested by the helminthic load on the human body. But in the wealthy people, why do you think there's so much allergy in the West? Much more than India. Because of the IgE issue, because of the helminth issue. So you shouldn't start immunotherapy too early. Dr. Khedekar, you're a big allergy practitioner. What is your youngest age? 5 years. Great. So all are agreed that about 5 years a cut.
So for milk allergy also, see, I have a 5-month-old child who had milk allergy. So in case of food allergies, they've been told to wait and watch till at least minimum 6 years of age because it might go off on its own.
Correct.
So that we have to see.
The earliest stage would be 4 years of age. But in that cases, the particular precaution that I would follow is that I would do an extra dilution for that thing.
Agreed.
Suppose routinely I'm doing an 1:100, so here I would do an 1:1000 dilutions.
So when do you decide? It's a very good point that Dr. Khedekar has brought up. What is your point when you want to do double dilution, so to speak? 10x dilution. When do you do it?
If your SPT response is too strong, which pseudopodias are there.
Okay, so gross pseudopodia, very strong response, you can always ask for a double dilution to start with. Now there's a lot of controversial discussion on adjuvant therapy, vitamin D and probiotics. How many of you are in favor of probiotics and vitamin D, madam?
Vitamin D, I would give them if their vitamin D is less. Okay. As simple as that. Probiotics, I don't have much of a data to prove.
Or disprove.
Or disprove, yeah.
No, but vitamin D, I think B12 and D3 should always be checked in our Indian population.
Yes, yeah.
And easier to treat also.
Yeah. It's low-hanging fruit.
I also supplement them with D3, not with the probiotics.
Hey, probiotics we will know in the next years.
Even explaining that
it's a new
it
concept.
has a role. And,
so probiotics are under evaluations and we have to see in the follow-up how it is working because it has come, all the theory has come up, but we cannot say how they actually work.
Not giving probiotic very regularly in that.
But sir, they are not harmless. I mean, they are harmless.
No,
so why not? I mean, see, we can improve our results if the probiotics are added.
Boss,
so
ultimately it's a function of money also for the patient. These are all self-paid.
But sir, we have natural probiotics. Add at least curd. To
In
this.
fact,
why not?
In fact, now that we are talking so much about gut health and all that, and I've clearly seen many patients getting rid of many of the allergies once they have changed their lifestyle, food especially. So there is a role for probiotics, but it will come in the next decade.
Yeah, that regional. So if you're from South India, then you should have your South Indian food. If you're from North India, you can eat parathas with health. That it affects the gut health also.
Probiotics I will consider in cases of children.
Yeah.
Especially.
Yeah. Okay. Good point there. Rupali?
A lot of studies now which have come in favor of probiotics, like the gut-lung axis.
Forget the studies. What do you do in your practice here? Studies to padh lenge hum.
So recent. I mean, there were not many companies who were like having this. So recently there have. So I have started recently.
You started giving?
Just recently.
To whom? Do you ask for gut health before you begin probiotics, or you arbitrarily give it?
No, so just arbitrarily.
Arbitrarily. Vikram, any other?
Probiotics, especially to children of hyper-anxious, affording parents.
That's a good point.
That's a good point. Good point. No, but I agree. See, that's the only answer that evoked some claps from the audience. Can you imagine? Okay. So, allergen immunotherapy in special populations. In pregnancy, do you stop immunotherapy or not? No.
We do not start it, but if it has been initiated, we don't discontinue it.
That's a very valid
Very,
point.
very important
That's a
point. Do not stop the immunotherapy. In fact, it helps the mother and the child to continue that. And any other points on that? So children, it acts the best. Pregnancy, continue the immunotherapy. Pregnancy, don't initiate immunotherapy. Take home message.
Biologics.
How many of you use biologics? Which one? Omalizumab, I mean, the only one.
Omalizumab. In cases of recurrent sinonasal polyps, especially central compartment Th2 type.
Okay. So there is a optimal use guideline. One is that you have to have Th2 disease for omalizumab because it's an IgE depleter. Second is that you have to be treated with systemic corticosteroids more than 3 times a year, or you are totally intolerant to systemic corticosteroids. Third is when you had more than 2 surgeries done. See, there are 2 things. One is a properly done surgery with recurrence and a badly done surgery. If it's badly done, you jolly well go and revise properly. But if there's a beautifully done surgery and it keeps recurring, then you look at AERD or you look at gross Th2, in which case you need to use this omalizumab. And continuous nasal polyp score of 2 or more for each side in spite of treatment, and sustained anosmia, rhinorrhea, and post-nasal discharge for more than 8 weeks. So this is the use. Choosing the biologics, of course. In India, we have no choice, but these are the biologics that are available for this. Mepolizumab, dupilumab. Dupilumab is an IL-4 alpha inhibitor. Mepolizumab is IL-5 inhibitor. Omalizumab is anti-IgE. And last
what is important to note is that for allergic rhinitis per se, you don't need biologics.
Correct. Absolutely correct. For lower airway and multiple polyposis, confounding your allergic rhinitis.
I think it's chronic urticaria.
Yeah. For that, you need serial IgE. But when you start biologics, you cannot start with a low IgE any which ways, then the biologic is unindicated. Now, as far as food allergies are concerned.
Ashim sir.
Yeah.
We are running out of time.
Okay. So we can wind up there. Forget food allergies. Thank you. So I want to thank the panelists, and I think it's lovely to have all of you here. Many of you I know for many, many years, and it's a joy. Thank you.
Thank you, sir. Now I would like chairpersons to felicitate panelist and moderator.
From here, ऐसे लोग वहाँ तो नहीं पहुँचे। दीपक आ जाओ। गौरव, come on man. Close in, love each other, give each other some love. Good. Thank you.
I would request Dr. Rajesh to felicitate the chairperson.